Well, good morning. I'm Mariann Yeager. I'm CEO of the Sequoia Project, and it is a real honor to be here this morning. I want to extend a very heartfelt thank you to the IHE International Board of Directors and the committees, and really to all of you for your interest in hearing our story. So if you're not familiar with the Sequoia Project, let's see if I can look at this. We are a nonprofit with a public mission, and our sole focus is bringing together industry and government to really try to solve the practical challenges that are really holding us back on enabling large-scale nationwide sharing of information in the U.S. And so this is our sole focus. This is all we work on each and every day. And we are unique in that it's our role to really offset the burden of the federal government and to try to solve interoperability by bringing together all stakeholders, both in government and industry, and to really try to tackle, again, the real-world challenges. In addition to that, we also support multiple independent initiatives, each of which has their own mission, their own governance, and their own structure. And we provide really the corporate support, a corporate home for them to do their important work. There are currently 3 initiatives that we support, one of which is the Ehealth Exchange. This is the largest and fastest growing health data sharing network in the U.S. We also realize that there will not be one data sharing network. There will be multiple. And in light of that, we knew it was very important to also provide a way for those networks to interconnect. And so Care Equality is really the forum where industry and government has come together. They have developed, through a consensus-based process, a standardized national-level interoperability framework that links all data sharing networks in the U.S., and that isn't just in the early stages of being rolled out. But again, in the spirit of recognizing there will be multiple data sharing networks, we felt it was really in keeping with our mission to figure out how to bridge those networks. And the third initiative, which is the newest, we are doing in conjunction and collaboration with the Radiological Society of North America, the RSNA. And as they were moving forward with their image share validation program, we felt we could blend and really bring to bear our expertise and help support and pilot an interoperability testing program which will enable the sharing of medical images. And thank you, Dr. Mendelson, for entrusting us to help you all with that. So the Ehealth Exchange, a little background about the Ehealth Exchange. When we think about networks, and this was actually a really important consideration for the federal government who actually started the Ehealth Exchange, was to consider what is in the best interest of the country. Is in the best interest of the United States to have a single national level centralized network through which all transactions flow. And I think the federal government took a pretty strong policy position on that back in the 80s with the breakup of AT&T, and they said no. So is it in the best interest of the country to have a completely federated network and just leave it up to the market to figure it out and just allow data to be exchanged over the internet? And there was a recognition there is a role for that, but for health information, probably not so much. And so really what the federal government settled on as a strategy back in the early mid-2000s is really more of a hybrid approach, that you would have these distributed, federated connections. There would not be a single national gateway, but there would have to be something in the middle to bind it together, to bind the different partners together. And that was really the model that the federal government, through the Department of Health and Human Services, and specifically the Office of the National Coordinator, ONC, Steve Posnick is here from that office, and Steve was there when this work first started. He knows all about that. And that's really where the Ehealth Exchange fits in the spectrum. And there's a role for all of these different kinds of networks. It's not that one network model is better than the other. But again, for the federal government to stand behind this, it really had to meet their policy objectives, and that was very plainly what it was. So the Ehealth Exchange, think of it this way. The Ehealth Exchange is really a community of exchange partners who have agreed to share data based upon a common set of standards, specifications, and policies. We call those rules of the road. There have to be a common set of expectations that the participants and their providers would have an expectation of a code of conduct, so to speak, and how they would conduct themselves and what rights they have to the data once it's exchanged, et cetera. It wasn't enough to just put forward those rules of the road. They had to be enforceable. And so the mechanism available through this community and what they agreed to abide by was to have those rules of the road enforced through contract. So there is a common data sharing agreement that all of the participants have signed. It's an identical agreement. There is one, and it is called the Data Use and Reciprocal Support Agreement. Long word, long name, but it's short for, we call it the DURSA for short, DURSA. And they also wanted to make sure that there was governance of this effort and that it was governed through a representative process by the participants in this network. So that is what the Ehealth Exchange in its simplest form. What is so very unique, and I think Charles and he and I were speaking, and he wanted to make sure that I conveyed today, was the very unique genesis of this network. This was not a private sector endeavor. This was not solely a government endeavor. This was an area where there was a vision to develop a nationwide health information network, and to do so in a way that was through a cooperative process. So back in 2006, ONC started working on the idea and concept and a strategy for a nationwide health information network. And what they realized and what they wanted to put forward was a way for them to incubate this work, where ONC provided their leadership, ONC provided the early support and incubation of the Ehealth Exchange. And in 2007, they issued awards to about 18 different private sector organizations, so a group of health systems and regional and state level health information exchange networks, and engaged 12 different federal agencies and formed what is called a cooperative. ONC was more of a facilitator. ONC brought this group together. ONC basically charged this cooperative to figure out how to make this work nationally in a way that there would be a common national level data sharing arrangement that worked both for government agencies as well as the private sector. But you'll notice the one word that is missing from this, and that is regulation. ONC was not going to regulate this, but to really allow the market in partnership with the government to figure out how to make this work. And I think I was speaking with a gentleman from Sweden, and I believe there's an initiative in Sweden that sort of, has a similar feel. But imagine back in 2007, in August of 2007, this cooperative met for the very first time. The time frames that they were given to do this were incredible. They were given 90 days to develop that first draft of a test legal agreement. 90 days. That you had to get the federal government and all these different agencies and all these different private sector groups to agree on what the policies were that they would all abide by and that they could live with for sharing data. And again, it was starting with what can you agree to minimally to share test data. So we knew, I will say we, the collective we, meaning ONC in the community, that it was going to be too hard to really try to figure out what the group would agree to if you were contemplating sharing identifiable personal health information. So they started with what would minimally you need for test data. Then within the first 6 months, they had to agree to and execute that test agreement. That entailed unbelievable negotiations and a real leap of faith. It was probably one of the most intensive initiatives that I was ever involved in. I was a contractor at ONC at the time. And it also necessitated clearance, not only at the Department of Health and Human Services, but the other 12 agencies. So this went through formal legal review. In some instances, it went up to the secretary or the assistant secretary of that agency to sign. And I can tell you that there were several issues that were born out of that. This is probably another conversation, but it really helped shape that test agreement. That was just getting agreement on sharing not even de-identified data, but, fake data, test data. And within the first 12 months, they had to execute the first production agreement. And this is where, they had to agree to the policies and requirements and legal provisions that they would sign. They had to agree to sign as a condition of being part of the cooperative. So imagine, the reason why I share that incremental approach is it was very important for the government to not just have a seat at the table. ONC is not a data sharing organization. They recognized their role was to provide leadership and a forum and support and to incubate for the private sector to be part of this. But it was important to have a singular approach that would work both with the federal government and the private sector. In parallel with the development of the legal agreement was the work on the implementation guide. So the government had identified a set of priority use cases, and there were work groups who developed based upon existing standards and developed implementation guides that they would, again, there was a commitment that they implement this. It wasn't just develop a spec and maybe somebody will implement it at some point in time. There was a contractual obligation that they actually implement and demonstrate to the Secretary of Health and Human Services a live demonstration of this work in progress. So all of that work occurred in late 2007 and throughout 2008. So we're talking a 15-month period, the first point in time this group first was introduced, right? So you're thinking August, these folks were just introduced. And by February of 2009, the first production exchange occurred. It occurred between the Social Security Administration. This is the government agency which provides monetary benefits to individuals who are disabled, and they need access to medical records to substantiate that person is disabled. And it was the first time that the Social Security Administration was able to connect to an IHE. It was the first production transactions, and that was, again, February 2009. So the Ehealth Exchange has essentially celebrated 7 years of production as of this year. And over time, it grew. And in about 2010, early 2011, there was a recognition. There were 4 federal agencies sharing data with about a couple hundred hospitals, and there was a recognition that this was not a proof of concept. This was a real data sharing network. There was real data being shared to treat patients and provide benefits. And there was a recognition that ONC, given its role with meaningful use and really being a policy office, that this endeavor would really be better served in the private sector. And so we basically, through, again, that cooperative process, worked with the federal partners and the private sector partners to determine, okay, is this worth taking and deploying on a larger scale basis, or was this a good experiment and maybe another approach is better and we'll write a white paper about the lessons learned and do something else? Each federal agency went back and independently determined that, yes, they wanted to make a firm commitment to take this work forward, and the private sector partners did accordingly, and hence Sequoia Project was formed. The company was chartered in 2012, and again, it was very important for these participants, since it started in the federal government, to have the Ehealth Exchange supported by an organization that had a public mission. So how Sequoia is governed, and thank you, you're so nice, was as important as the charge. So in October of 2012, the Sequoia Project assumed stewardship for the Ehealth Exchange. At that time, there were a couple hundred hospitals, I think maybe 26 participants. And then the next 3 years, the network quadrupled in size to where we got it today. Today, the Ehealth Exchange is the largest data sharing network in the U.S. Data is being transmitted across all 50 states, connecting nearly 50% of all U.S. hospitals, tens of thousands of medical groups, more than 3,400 dialysis centers, more than 8,300 pharmacies in the U.S., supporting 100 million patients. The data sharing also enables the connectivity to 4 federal agencies, so the Department of Defense. The Department of Defense this month is rolling out connectivity to enable records to be shared for their 9.4 million beneficiaries, so that's active and retired military and their families. It also enables the sharing of records for veterans and their families. And to give you another statistics, there are 9 million veterans in the U.S. today. There are projected to be 21 million veterans in the coming years, and more than 10 million individuals in the U.S. who receive benefits from the Social Security Administration. And again, enabling the sharing of records for more than 100 million patients and growing. So today, I think there are 120 participants in the Ehealth Exchange, but it actually represents, they're aggregators of connectivity. So it really represents the statistics I shared here. When you think about the Ehealth Exchange and what it was really set up to accomplish, it was really grounded in a foundation of core values. Again, to enable the sharing of data between the private sector and the federal government, it was more than a technical project. It was absolutely about getting governance right. If you think of the Ehealth Exchange as anything, it's governance. It's governance between the private sector and the government. And so if you characterize that, it was really important to really identify what does there need to be minimally agreement upon and allow innovation to occur on top of that. But the Ehealth Exchange also wanted the governance to be open and transparent, to really invite inclusiveness across diverse stakeholders and make sure that there was accountability. It wasn't enough to just say, here are the rules of the road, everybody agrees to comply. There had to be an accountability and a process to exercise. So, for instance, here's an example. If there is a dispute or a disagreement on the interpretation of a specification, there is a process to take it through. if there is a concern that information was shared in an inappropriate way, that governing committee, the coordinating committee, is the body you take it to. So it was very important to have a way for these partners to really trust each other. In many instances, providers who are sharing data via the Ehealth Exchange have no other relationship with the other providers they're sharing records with. Again, the foundational building blocks for the Ehealth Exchange are built around trust. So there's the legal agreement I mentioned. It's governed by a committee called the Coordinating Committee. You'll notice it's not really a regulatory framework, and the title of the committee actually warranted some discussion. So there are many different titles contemplated for the committee, and what was agreed upon was a concept I think that's used in the UN, and that the committee should really be entitled what its function is, and that is coordinating. So their goal is to really, through that cooperative governance, representatives on the committee include the participants who share data. So the Health Information Exchange networks, health systems, government agencies. ONC has a role on the coordinating committee. It's non-voting. And the recognition was that if you're not if you don't have skin in the game, that's a U.S. thing, if you really don't have yourself being a data sharing partner, yes, the government has an important role to play. It's to assure that the network really is consistent with federal policy objectives, but you really shouldn't have a right to make decisions about the network if you don't really have any consequences yourself. The coordinating committee can delegate responsibilities to others to fulfill their, so they've actually delegated to the Sequoia Project to do certain things. And the only authority we have to do any of this, to support testing or onboarding or staffing, is because the coordinating committee has formally delegated to us in writing that right. They could technically select somebody else if they wanted. So there are a few technical shared services. One is the phone book. It's a web services registry. This is actually a waning technology. It's based on UDDI. There is a process in place to pilot a Firebase directory to replace that. This is like a phone book of participants and the providers and their technical endpoints. And there will be, I think, a recognition of that directory should also interoperate with other FHIR directories as well as HPD directories. It was very important that the participants agree on a security model. They do use X.509 digital certificates. This is an area that initiated some initial debate about should there be a common digital certificate, and the answer is yes, and there should be one that works both the federal government and the private sector. And so Sequoia, for instance, we've been delegated authority to manage those digital certificates. So if a participant has an Ehealth Exchange certificate, you know that they have abided by the terms of the DRSA, that they have been tested, and they can be trusted without any additional really negotiation. And the other shared capability is testing. So while we would like to think that all of these standards and implementation guides just work and you can interoperate without any other special effort, that's simply not the case. And so testing is another important component of those shared capabilities. There are several use cases. The idea is the Ehealth Exchange provides a foundation for really any use case. So the initial set is really centered around treatment and care coordination, the ability to also provide better coordinated care for military and veterans and their families. The Social Security Administration requests millions and millions of records every year, largely in paper. So the Ehealth Exchange enables those records to be retrieved electronically, and instead of that benefits determination taking 6 to 9 months, those benefits can be determined in a matter of weeks. So imagine, in the U.S., if you're disabled, you're not able to work, how do you pay your mortgage or your car payment or groceries? And imagine if you had to wait 6 or 9 months to determine if you qualified for monetary benefits. So there's a real human benefit to what we're doing here beyond just, this interoperability objective. It also enables the transmission of quality measures. More than 60 million quality measures are transmitted to CMS, which is the government agency who oversees the Medicare program, every year for their end-stage renal disease program. It also enables the sharing of immunization data. I don't know if you realize, but if you've ever heard of a company called Walgreens, they're the largest immunization provider in the U.S. behind the federal government, and every Walgreens in the country is able to share immunization data now with the Veterans Health Administration, and more recently, CVS Minute Clinic, which is another large provider, is similarly able to do so. And then there are other use cases as well. Can we use these capabilities to provide consumers access, et cetera? And then there are corresponding standards identified for each use case. The point of this slide is really this. If the community wants to support a new use case, they decide which standards and specifications they support. So the network is not really built around a single technology. It was designed in its very nature being largely governance and minimal shared services to enable any use case. So here is the architectural layer. This is how there are 4 levels which support the use cases that are in place today. The very operational level, I think I managed before, there's managed PKI and a web services directory, which will soon be provider directory. There could be a new box there. And actually the community is discussing new shared services that they might need to enable new use cases. Layered on top of that is really the transport and the security layer, and also the ability to convey policies. It was important to support automated workflow and to enable the policies to accompany a message. So the role of a person requesting data, the purpose for which they're requesting it, etc. So it was really important to think from start to finish how to enable this to work end to end. Layered on top of that are the different exchange patterns or methods. It can support multiple. So those services and the operational infrastructure can support query, retrieve, push, publish, subscribe, consent, really any, and others as they evolve. And then really on top of that, you can support any use case. So today that's largely summary record, quality data, immunization data. It could be really any number of things. Here are the IHE profiles that layer on top of each of those services. You can see that the network is built upon a very solid foundation of IHE standards and others. In terms of the clinical summary, it's the C32 is one, but also consolidated CDA, and then there are going to be efforts to pilot FHIR and other capabilities as well. So how does this work in practice? So here we have 2 participants, each of which has their own gateway. One acts as an initiator for a request for data, and the other is responding. So first, you search for records, and so you send a request to the other partner, and do you have any records from Mariann Yeager? They search for records, and if a patient is found, then they will actually return and let them know that, yes, in fact, we do have records from Mariann Yeager. At this point, the initiating participant sends a request for the records, and then the responding participant searches for documents that they have that meet those parameters, certain dates of service, date range, etc. And they can either provide a list with those records or 0. And this is an issue that's very interesting. It actually warranted a lot of discussion. What happens if a patient has not consented? If you have records that the patient has not consented, there was a decision made to respond with information not available. So that was sort of how the group resolved that. That was actually an important decision point because we consulted ONC and said, what would be the best response? Is privacy protective? That's also meaningful. So again, having the federal government and all their policy expertise to really inform this work made sure that the network operated in really the public interest. And then request to retrieve the documents, they transmit them and return them with relevant documents. So that's how the simple query retrieve works today. So what does it take to onboard to the Ehealth Exchange? There is an application process. It used to take 4 to 6 weeks. Now it takes about 1, because the whole idea is to minimize the burden. Testing is an important. Each participant does practice testing in an automated test lab. Our team validates the results, and if they pass, then they're accepted by the coordinating committee, the CC abbreviated here, and then at that point they're issued a digital certificate and they go live. There are 2 types of testing. One is at the participant level. It verifies that that gateway actually complies with the specifications. What's unique about it is not just conformity assessment. Conformity assessment is helpful in making sure that products, health IT systems, are capable of exchanging data. Rather, it was important to also focus on the known issues with interoperability. There are 7 years of production experience, and it was important to focus on those issues, prioritize those, and to also focus on known security issues. So there was a concept called negative security testing, where the system will form a malformed security header, for instance, and our program actually tests to make sure that the system rejects it accordingly. This is required for new participants, for existing participants as well, because if you change your system or if you add new functions, we need to retest. What we realized was it's really burdensome to test hospital by hospital, site by site, network by network, and so there was a recognition early on. It was important to make sure that the systems used for data sharing were really interoperable out of the box. And at the time, there really wasn't a program that focused on the scope of testing that the network needed. And so it was a function that Sequoia started. We're very much hoping that we can leverage, and in collaboration with IHE International, work more closely with you all on that. But the whole idea is if you have assurance that the product interoperates, we've actually seen we can reduce the testing for participants by more than 50%, and that number is actually whittling down. As a nonprofit, we're not looking to make money from testing. It's something we simply have to do to have assurance of interoperability. And our hope is that as the health IT systems mature, we're actually starting to see that the need to test is actually being reduced. So that, again, the idea of having testing is to assure that issues aren't introduced into production and then perpetuated as a security vulnerability, for instance, throughout the network. There are currently 12 health IT platforms which have been validated as Ehealth Exchange compliant, and others going through the process. And what this means is that their customers do very little, just security tests. So they've really baked in interoperability, and then our team basically does a set of quick automated security tests, again, whittling down the testing and onboarding process from months to just a handful of weeks. So what is the impact of this model? There is an ROI, return on investment, by having a common trust agreement, shared governance model, and a common set of rules of the road. When the federal agencies contemplated setting up their own networks, when there was a decision to move this endeavor from ONC to the private sector, they realized it would cost them hundreds of millions of dollars to set up their own network. And the legal agreements alone, out of the gate, was a savings of more than $60 million. There's also benefit of having access to information more broadly. So if there are national level providers or pharmacies, they really don't want to establish 50 different data sharing arrangements, not just technical connections, 50 different contracts. And so they realized by having a common legal agreement that would accelerate technical deployment. It enables sharing with the federal government. And of course, because the Ehealth Exchange is governed by the community itself, they in fact determine what they want to support going forward. Benefits to the patients who receive care, certainly disabled individuals who are able to get their benefits on a more accelerated basis. Providers have access to information on a more timely basis than ever. We are seeing very specific instances where it's making a difference. There was a veteran, one example, just anecdotally, who had an organ transplant, and they had a really complicated recovery. And when this patient, she was actually discharged, and she had started having health issues and went to another hospital. They were going to admit her and do a whole set of lengthy tests. They queried for her records, discovered she was an organ transplant recipient, and that she had not been taking her medications. And so they were able to rectify the situation. They avoided a costly admission, and that person's, basically didn't have to go through unnecessary. And of course, the ability to share data with active duty military, their retirees, veterans, and their families. Individuals who receive 70% of their care in the private sector, they have some of the most complicated care in the U.S., and this really does make a huge difference to them. So, lessons learned. What did we learn from building this network? So, Charles, in the spirit of top-down, bottom-up, I don't know that the Ehealth Exchange would have been as successful if we did not have ONC's leadership, because the stakeholders wouldn't have been given that singular focus, that singular charge of here are specific deliverables in a specific time frame. We're not bending. We're not, and the very specific use cases. Also, by having strong government support as implementers, these federal agencies participated in the pilot. They had to make investments. They couldn't waffle. It wasn't conceptual. This is real-world implementation. These groups were coding and testing and taking it through legal processes and exercising everything you do when you try to establish a connection. And it was really those federal engagement that drove early adoption. Federal agencies in the U.S. are really valuable exchange partners, and they really brought the private sector to the table. Meaningful use was a great stimulus, but the future and really using this connectivity, because the U.S. is more wired than ever in our history, are really alternative payment models. But where the Ehealth Exchange really thrived was that bottom-up approach. So it really wasn't about prescribing and dictating, regulating a particular set of standards or policies, but it was really driven by the practical users and the providers and patients who were involved in the demand to really have this work better. But it was also the private sector and the public-private came together to collaborate on the implementation level details. So it wasn't a private sector solution, it wasn't a government solution, it had to work for both. And so we are seeing now as health IT technologies mature and they're starting to focus on how do you improve workflow, that it really is this innovative and working out the details from the implementation community that has really made this real. There are lessons learned from having a common legal agreement. It eliminates one-to-one legal agreements. Again, they're real return on investment. And for a national network to succeed, you really can't have partners agreeing to different side agreements here and side agreements there. You have to have everybody really sharing on a common unified set of policies and expectations. And there is real money saved when you have a shared governance model, because you have a source of accountability and a forum that engenders trust. And really, that's really at the heart of the Ehealth Exchange. It was important to have contractual enforcement of compliance and to have that done in a manner that's transparent. All the contract, the operating policies and procedures are all publicly available, so there's no really, all the specifications and the details are all open to the public. And what it does is it really removes all doubt about how you expect partners who might be, once, twice, or three times removed. Testing has been absolutely essential. When testing and onboarding started, when it was supported by the Office of the National Coordinator, it was completely manual. So a partner would send a test file, an individual would manually review it. There'd be a lot of back and forth negotiations, series of calls. It took months and months just to get a single connection live. We knew when we supported the Ehealth Exchange that it had to be automated because it's not sustainable otherwise. And so it was very important to develop a very rigorous automated testing process that would really provide a test environment for vendors and participants to practice tests and then have an objective review of the results. It was also important to make sure that we weren't putting into place something that never changed, which is why we don't call this certification. The coordinating committee wanted the ability to adapt and evolve, and if we started to see the implementations improve over time, to only test what was really might be broken. We've actually seen the scope of testing started out rather comprehensive, and it's now whittled down to just a handful of security tests in most instances. Now that we're seeing transport and security are virtually turnkey, unless it's a new vendor coming through the process for the first time, the focus is now shifting to, well, let's test what's actually working in production. Because when you test test implementation or in a test environment, it's not really representative of that system as it's configured and set up in production. And so what we're realizing is, well, testing in a test environment is helpful. It gets you most of the way there. But we'd like to see our program focus on testing in production, testing more rigorous content, testing patient matching, testing security and service level monitoring, and also making sure that as a good steward, we're not holding all of those lessons learned to ourselves, but we contribute them and share them publicly, and we contribute them back through active engagement with standards development organizations. We would much rather have IHE and HL7 and the standards group incorporate the lessons learned into their specifications and to do the testing so we don't have to. So this journey toward seamless interoperability. Everybody talks about seamless interoperability in the U.S. and how it seems to be this elusive goal. And, we like to quote Wes Ruschel, who's really one of the greatest thought leaders in U.S. in this space. And this quote is so apropos. Flexibility and optionality are the enemy of interoperability. Thank you. We see it. We live it. Optionality and flexibility are great when standards have multiple purposes, but in a network, it has to be constrained. Tightly constrained. And even though the implementation guides we have in use today are very constrained, it's not enough. It's not enough. And so the key is, rather than trying to get everything constrained and testing and specifying every possible scenario under the sun, what we realized is, particularly as a small company, and Dee Davis, we had to focus on where do we have to be really, really, really prescriptive and tight. Security, you bet. Known interoperability issues, we know the data points, we know exactly where it's going to be a problem. Focus on that. But yet these very precise specifications are elusive. And standards bodies continue to develop great work products, but now I'm looking at the latest specifications, even with FHIR, and I'm looking at my team saying, we're going to have to do another implementation guide to actually deploy this. And that means we have an implementation guide for the Ehealth Exchange network. There are other networks and other groups out there who might take that same specification and constrain it differently. So we really think that this is sort of a blind spot, maybe not a full recognition. I think the community at large recognizes, and SDOs do as well, that we need more specificities. So the question is, who does that? Right now, we do, because we have to, and no one else has really done it. So if the specification is testable, then you've won at least a good part of the battle. It's very important to really really have demonstrated evidence that it does. And really, seamless interoperability goes way beyond transport and security and web services. There seems to be a lot of debate in the U.S. about transport, security, and web services. Folks, that's turnkey. That's a teeny tiny part. We need common data sharing policies. We need to address patient matching. We need to fix and have better content. This is a real scenario. In the U.S., so we have all this connectivity, more wired than ever, to enable data sharing. Yet, if a provider can only get records from 30% of the providers in their community, are they going to use that connection if they have to go somewhere else to get the remainder? Probably not. What if they are able to access records, but the quality of the content they receive is not usable? How many times will they try before they abandon that connection? Or worse, what if they send a request and it fails 90% of the time because there's not good demographic data on either side, or there's a timeout or some other networking issue? How many times is a provider going to try to make a connection and it fails before they abandon it? That is a universal challenge in the U.S. So we have more progress than ever, yet it's ours to lose. And it's not just an issue with the Ehealth Exchange, it's a universal issue. There are real costs and savings to have this cooperative governance, this cooperative network. Our goal is to make this free. If we are successful, these transmissions become a commodity. It's just a dial tone, and it should be virtually free. Sequoia is not out to try to establish this footprint and be the monopoly, and you have to go through our initiatives or you can't connect. We want this to just be so integrated into workflow and every system that it just works. And that really the cost of supporting governance and supporting that common trust agreement is pretty nominal. So the incremental cost of adding a new exchange partner is pretty model. Network testing is not a profit center. It's something we have to do. In fact, it's kind of a loss leader for us. So it's something we have to do as a condition of getting participants on the network. We are not a testing entity. And it's just, there's not a lot of really a business for us, at least, in testing. We're hoping someone else can really pick up that agenda. If we do more rigorous testing up front, it's dramatically lower costs for participants longer term. So if you do more rigorous testing with vendors, you have much less testing with providers and their customers. And then again, this is not possible without automation. So where are we focusing our energies in 2016? Well, in a federated environment, there's not a single connection point, so it's hard to do network monitoring that you would in a typical centralized network. So the coordinating committee has developed guidance on response times and uptime, and there's guidance in a voluntary scorecard approach that's been adopted. We will be implementing more of a monitoring service using test patients to have greater assurance of response time and uptimes. And again, the idea is that if there are pervasive problems, we have evidence to bring back to the coordinating committee and to really assure that there's this continuity, the service level expectation across the network. We need to continue increasing connectivity in the Ehealth Exchange. The Ehealth Exchange grew by 20% in 2015. In the first 4 months of this year, it grew another 10%. So it's easier to connect. So that accelerated connectivity. I think I mentioned provider directory. We are participating with the Argonaut project to pilot a FHIR-based directory that will, we hope, serve as enable us to communicate with other provider directories, both FHIR-based and HPD. We want to shift dramatically the testing approach away from verifying what a product looks like in a test environment to let's test to make sure it's actually working in production on a continuous basis. We must improve content testing. This is truly probably one of the greatest risks we have. The connections exist. The data is not valuable. That's a problem. Really under Dee Dee Davis's leadership, she has really spearheaded a content testing work group. We recognize this is an issue not only with the Ehealth Exchange, but universally. And so we were able to bring to bear lessons learned from 7 years of production and very discrete implementation level issues. These are the problems. These are the things we need to fix, have a more constrained guide. This is around consolidated CDA. Again, contributing the learnings to HL7 in the hopes that they also incorporated into the standards. And then patient matching. We published a paper which was the result of a 2-year study with a collaborative group. Jamie Ferguson is one of them here, called the Care Connectivity Consortium. which includes the leading health systems and really pioneering in the country, Kaiser Permanente, Intermountain Healthcare, Mayo Clinic, Geisinger, and Ochen. And we said, what can we do today with existing technologies to improve patient matching? And we realized there is a way to dramatically increase it from 10% success rate to a 90 to 95% success rate with existing technologies. A widget or a technical solution will not solve this issue. There are issues with the data. There are issues with normalizing the data, standardizing the traits, having good combination of identity traits for matching. And so that's an area we'll have real important focus. So we know what we need to do. What's important is how do we solve these issues? And now with this meeting, it's not just solving them for the U.S. How do we, as a worldwide community, make this better? And in our experience, that means coming together. We need to come together in forums like this, share our experiences, convene. And when we identify common problems, we need to collaborate, again, industry, government, U.S., worldwide, to find out how to solve these things and then put them into practice. Sequoia doesn't do conceptual white papers. There are other thought leaders that do that. We're the real world, roll up your sleeves, implementation people. And so when we work on something, it's something you can put into practice. So with that, thank you all so much for your time and attention today. I hope this was helpful, and I look forward to talking with all of you after the break. Thank you. You still need me, okay.
Wow.
Well, I thought I was up. Get up.
Well, I knew it was coming something very great on us, but after hearing the details from you, I'm actually overwhelmed. It seems that you found it,
I don't know.
At least you found it for your project. But I'm sure we will refer on that perhaps maybe in the next panel one, which deals also with the topic of coming from project operations. But are there any questions from you to Mariann now?
Hello. There we go. So from a patient's perspective, how would this sort of appear that I'm, if I'm, let's say with Kaiser, and so I've just arrived from, across the country, I say, oh, I've got some records in, I think this is the name of the hospital, what does it look like?
Well, it's in Kaiser Permanente's instance, and Jamie can speak to this more authoritatively than me, it's their electronic health record that has standardized gateway that is able to search for those records. Today, with the Ehealth Exchange, it's largely driven by referral patterns, likely places where that patient's received care, geographies. We really don't promote broadcast queries across the country because of the sheer volume. And then there are also ways the patient can indicate. So you can really narrow it down by geography or exchange or a particular endpoint if you want. Mm-hmm.
Mariann, thank you. Interesting speech so far. ONC, I was curious, who is paying for the ONC organization?
Well, ONC is a federal agency, so taxpayers pay for ONC, Steve. But the Sequoia Project, we are sustained independent of any federal funding. So the participants in the Ehealth Exchange network pay a very modest annual participation fee. These fees are public. So for a small organization with under, I think it's $1 million in annual revenue, it's about $4,000, $5,000 US. If you're a larger organization, it's $10,000 US. And if you're a large institution like Kaiser Permanente, $20,000 US. So it's not an exorbitant amount. Again, it should be even less.
Good morning.
Good morning.
So I think very interesting speech. My name is Mariann Wessels. I sit on the IHE International Board. I was wondering, can you comment as to how you worked with IHE USA or IHE International as you went through this process?
Well, it was important if we're going to really put into practice the work of IHE and IHE International, we felt that the best way to be a good steward is to be actively engaged. Thankfully, we have two individuals on our team, Dee Dee Davis, who I know everybody knows Dee Dee. So we really wanted to be more than just a passive participant, but really to bring back feedback to IHE. We do that through direct participation in IHE International.
I'm Mariann, Mike Nussbaum, IHE Canada. Great presentation. In the spirit of globalization, the lessons that you've learned in bringing together networks of networks, a network of networks to satisfy a national infrastructure. And you're obviously here addressing an international audience of 23 some countries. What are the capabilities of the Sequoia Project that could be lessons learned for other countries? And are you in discussion with any other countries or regions about duplicating some of your successes?
We have not been in active discussions about duplicating in other countries. Well, we've had some meetings with a contingent from Stockholm, more lessons learned. I don't know how much of what we're doing in the U.S. really translates to other countries. I would welcome and embrace any conversation that you all would like to have and explore that. We have been contacted by a health system in the Netherlands who happens to host a festival every summer, and they wanted to be able to interconnect with the Ehealth Exchange because they end up treating a lot of Americans apparently during that time. And it should work. We have the International Foundation. It should be possible.
Hi, Mariann. Elliot Sloan with IHE International Board as well, and your work has just been awesome over the years. Thank you. Leadership. I had an interesting question from a colleague, the Minister of Health in India. How would this scale to 1.25 billion people?
It depends. I mean, what's their, what IT systems are they using and relying upon? What we found is this can and does scale. And there was so much speculation early on about, this whole architecture, it's never going to scale. Well, frankly, that's just not true. We have the stats to prove it. Now, there are certain things you can't do. Again, you can't broadcast query, but it probably, in a country of that size, that having regional and geographies and different centralized connection points, whether it's through a technology vendor or a regional network or whatever, I think there are many different ways to address it.
One last question.
For sure.
Good morning, Karima Bourka, IHE France. I have a question about policy, security policy, patient consent security policy, and so on. You are exchanging data between states, is what we call in Europe cross-border exchange. Mm-hmm. So I suppose that in each state you have different kind of policies. Mm-hmm. Was it very easy to try to find a consensus between all the states?
Look again, Steve. Absolutely not. So the issue of consent is an interesting one because we realized there was no way to have a harmonized, consistent way to address consent. So the policy in the Ehealth Exchange is one of local autonomy and the concept of applicable law. So each participant is obligated to comply with the own body of law to which they are required to comply, and that they have autonomy to really determine whether or not to release information based upon their own consent policies. They just have to be equitable and fair. They can't require consent for one group and not another. So a good example of the impact of consent, this is actually a huge issue, is there's been a whole debate for many years about is opt-in better or is opt-out better. Opt-in has failed. 3% of U.S. veterans have opted in to agree to have their records shared. And now the Veterans Health Administration is going to Congress to have that law changed because veterans' health information is not accessible. Patients who have had their records have the ability to opt out. We're seeing massive volumes from them. So it's a huge disparity in the U.S. on that policy alone.
Thanks for this information. Austria did the right decision. So after the last question, the very last question from Charles.
So we've heard what you've achieved in a sense as a national backbone, let's say in a simplistic term, federating multiple communities. How come at the community level things in the U.S. are not working in such an effective way? Why does not translate at the level down? Is it because the federal leadership doesn't apply, the state leadership doesn't apply, the community leadership doesn't apply, the funding is the issue? You have a little bit of a clue? I know it's outside of your scope. You've been carefully staying at arm's length. Any comments?
We could probably have a talk just on that. It's a hard issue. I think it's multifaceted. One is that regional networks that were born out of a real business need and had a sustainability and a real service that met the needs of their customers have done extraordinarily well, really well, and continue to do so. I think the challenge is many of the regions and states, when they got this wonderful federal funds, ended up developing their own really heavy footprint of infrastructure with an MPI and all these services and technology. It's simply the population cannot sustain it. So I think there might, if the HIEs start having more shared services, it's technically viable. There's a lot of phenomenal work going, even some of the folks who are struggling, but I think sustaining that footprint in very small regions is just hard. But there are other reasons as well. Well, thank you again very much. Thank you for
Thank you again.